sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I'm joined today by Mike Havig, MD. Welcome to the big show, Mike.
Hey, thanks for having me, Ray.
Great having you here. So our paths crossed, or at least we breathed the same air at Health Rosetta Fest in DC back in September.
Mm-hmm.
And we reached out, and you were kind enough to come on and tell us a little bit about what you do and your practice, how your line intersects with the healthcare system here in the US. But before we get into all that, why do you want to become a doctor?
Oh, great question. Well, I tell you, I always was interested in sports, played sports in high school and into college. A lot of friends, would get sports injuries. I fortunately never really had any myself, but I just had this interest in sports medicine at an early age. And that was in part because my father was actually a physician too. So he was a cardiothoracic surgeon. And I kind of liked the idea of taking care of sports injuries more than heart bypass surgery. Seemed a little less intense and a little more fun. And so I went to college thinking I'd go into medicine or maybe be an architect. Those were my two career paths, and ended up kind of veering down the medicine path. And, as an orthopedic surgeon, I kind of share my love for kind of designing and building things, fixing things that are broken, I suppose, with kind of the desire to practice medicine. And so ortho is kind of a hands-on builder kind of specialty in healthcare, I would say. And so it just fits my personality pretty well.
So you were kind of preordained to be a doc, right?
A little bit.
It's I always love when I talk to folks like you, because it seems like sometimes it's, you're the OG in the family, right? You're the first person to go down the road of medicine. But in your case, your dad was obviously a skilled surgeon. Well, I can't say that he was skilled or not, but he was a surgeon.
Yeah.
And that impressed you enough to say, yeah, maybe this is something that I'll explore. And orthopedic surgery is pretty cool because it's kind of the blend or the merging of, I don't know if this is appropriate, but in my mind, I think a lot about like engineering when I think about an orthopedic surgeon. And just, I think what's cool to me is I'm a thinker and a problem solver. And so I think there's a lot of problem solving in what you do. Am I right to say that?
Yeah, that's correct. I think, there's a lot of orthopedic surgeons who are biomedical engineers or mechanical engineers in their undergrad degrees. I am not, but like I said, I like thinking out problems and putting things together and try and improve processes, make them more efficient. I mean, that's just kind of my personality. And yeah, in orthopedics, someone's got a badly broken tibia and kind of like trying to figure out how to put the puzzle back together and what you have to think about biomechanics and understand kind of loads on structures and different modulus of elasticity. I guess the plural is moduli of elasticity. I don't know, but just a lot of stuff goes into it. But yeah, it's kind of, I don't know if that's correct or not. Again, as I said, I'm not an engineer, but
right.
I play one on TV, I guess I could say. But
oh, that's funny.
Anyway, yeah, so it's cool. Like, yeah, I like ortho. It's got a lot of new technology too. I think you could say that, healthcare in general, there's new technology, but I think some of the specialties have the most kind of innovation on a device side or engineering side. I think, cardiovascular medicine and probably orthopedics, where there's always new little devices coming out that make our patients' lives better and make our jobs easier. So it's kind of fun to have paced through some of those changes over the last 20 plus years. So
yeah, it's pretty cool with advancements in medicine. So do you have a specific area of specialty?
Yeah, I do primarily knee and shoulder surgery. So during your orthopedic residency, which generally is a 5-year deal after medical school, you're trained to do a little of everything in the musculoskeletal system: foot and ankle, hand, spine, shoulder, knee, you name it. And then a lot of us will do a 1-year fellowship after that to subspecialize in, say, hand surgery. I did a sports medicine fellowship, which ends up being a lot of knee and shoulder surgery, a lot of soft tissue reconstruction. But then that knee and shoulder specialty kind of morphs into reconstruction as well when you start dealing with older athletes who kind of may worn out their parts or broken parts early in life. They get a little later in life, and those things now need to be reconstructed. So 98% of what I do is knee and shoulder surgery, and that runs the gamut of fractures to soft tissue reconstructions, ligament repairs and tendon repairs and reconstructions, and also arthroplasty, so rebuilding joints, replacing joints of the knee and shoulder. So yeah.
So this is, I'm going to ask you a bunch of stupid questions, I'm sure, because I don't do what you do, but I'm fascinated by what you do because, you think about the way that our joints are connected, and you said soft tissue and stuff like that. So I would think, some of the more complicated stuff that you have to do is in that area, right? Bones are structural, but then getting the connections right. How do you even do that? Like, you often hear that someone will say with a shoulder, like, I ripped the muscle off the bone. And I don't know if that's technically accurate or not, but when that happens, do you use some crazy glue, or what do you do to get that patched up?
No, that'd be kind of cool if we could just glue it down. And there's various tissue glues out there for like skin, superficial lacerations and things that's been around for a long time. Yeah. So when someone, quote, rips the muscle off the bone, usually it's a tendon. The tendon is what attaches muscle to bone. So I always tell people, I always try and relate things to like kind of a mechanical device that most of us are familiar with, right? So for example, like with joints, like a shoulder, for example, I'll say, okay, well, think of your shoulder as a machine. The muscle's the motor, the tendon's the drive shaft that transfers the power of the motor to the moving part, the wheel, if you will. Then the joint, the ball and socket's the wheel. And so where these usually tear would be at the tendon bone attachment. So technically they torn the muscle off the bone, but it's really the tendon. And we basically go in and reattach it. And you're right. I mean, there's some subtleties into how much tension you apply when you reattach it to get it repaired anatomically, not over or under tension it. And, a lot of that in healthcare has traditionally come from basically experience, quite honestly, and just understand the anatomy and, matching, the two pieces of the puzzle together, if you will, the end of the tendon with the place that belongs on the bone. And now there's more sophisticated ways to do that. In joint replacement, for example, I've been doing robotic surgery for the last 15 years. I was kind of an early adopter there, where you can do the case without the robot, fine, but the robot just adds a level of precision. And so you can kind of combine your knowledge and experience. Probably you're going to make the right call the majority of the time if you're an experienced surgeon, but the computer and the robot just is, you can fine tune, right? Like you can really get a better degree of accuracy. So a lot of the surgical robots that we use for, say, joint replacement, they have sub-millimeter accuracy, right? 1/10 of a millimeter make a difference. Clinically, maybe not, but I don't know. I'm kind of a precision person. So the more precise I can do something, I think the better, right? And I may not be able to prove that in a clinical study, but I don't know. I'm also a commonsensical thinker, right? Like I'm a rational thinker. You can say, well, maybe you can accept a few millimeters of inaccuracy and still do okay. But if you don't have to do that and can do it in sub-millimeter accuracy, why wouldn't you, right? That's kind of my attitude towards it, at least.
Yeah. And so I'm sure that didn't happen overnight, though, right? As I understand that you have to put your reps in, and there's a lot of hours of training that go into being able to use a robot in a procedure. You don't want someone that just kind of is using you as a test case, right?
Yeah, exactly. Yeah, that's true. I mean, at the end of the day, the steps of the surgery are the same. The robot just adds precision. But yeah, certainly with all new technology, there's generally continued education and learning that goes on where, generally, you go to courses and go to a lab where you're performing a surgery on what's called a sawbones, which is kind of a fake kind of bone, but it's got the same kind of consistency for a saw or drill to go through, and you can implant devices in it. Or cadaveric labs too are kind of a mainstay of training. There's some really new and exciting. I'm not an expert on this by any means, but a few of my colleagues in ortho have also founded companies, and there's a couple there in the kind of VR training space, right, for training surgeons, where you get a really kind of realistic experience on, exploring anatomy as you're dissecting through a knee, or you can do a virtual knee replacement, for example, and things like that. I mean, it doesn't 100% replace kind of doing it, obviously, but if you can build up a couple hundred reps digitally, and then maybe it only takes 2 reps in real life to get it right, or 1, or versus 10 or 20 or 30 or whatever, in a lab or something. So I think there's a lot of cool stuff going on in the virtual reality space when it comes to training surgeons, and also, I mean, a lot of other trades, obviously, as well, that works for.
Yeah, I for the first time a couple of months ago, I think over the summer, I did a demo with the Apple VR. I don't know what the product is called, Apple Glass, whatever it is.
I forgot what it is. Yeah.
Amazing. Like, just stunning what you see visually. it's the immersive aspect of it. And I would imagine the applications, as you say, for medicine are just incredible. Just being able to, replicate a real world, application and participate in a surgery without participating in a surgery.
Yeah, exactly.
Pretty
Yeah,
cool.
I think that's pretty exciting because training programs, and we could do a whole podcast on this, but healthcare education, physician education has changed a little bit over the years. Where it used to be kind of baptism by fire, where you were like, I was kind of at the tail end of that in my residency, I guess, where you might work every other night and be up 36 hours and be off 12 and do that for extended periods of time, and you just you get a lot of experience doing that, particularly if you're working at a big city trauma hospital like I did in my training. So you get a lot of at bats, I guess I would say. Some programs you don't get as much of that, but just the way training's changed in the last number of years is there are more limits on work hours for medical residents and things like that, which I think is probably good physically and mentally for the medical residents and whatnot. But it also means like nobody wants to do an extra year of training though. So people lose, a year's worth of experience to some degree because some of the studies have shown. So the question is, how do you make up that year? Because now you're not doing 36 on, 12 off occasionally. Or in my case, that would happen when someone's on vacation, but generally we're on basically, we were on call every third night, and every third night you'd be up basically 36 hours.
Oh, jeez.
And so because you work 24 hours and you had to work the next day, like you
Right.
didn't go home. Now you go home the next day if you're a resident. So, but yeah, how do you make that up? And I think things like VR and some of these new things are a way where people can get those at bats, if you will, and hone their skills without having to spend another year or two in a residency program to get the same level of experience and come out as a doctor who's going to be able to efficiently and adequately do their job. Right. So
I read recently they're talking about up and coming doctors that are going through their residency that quote unquote are more concerned and focused about work-life balance, and they're not. I guess there's pushback going on between the old guard and the new guard.
yeah.
Where folks like you who have kind of paid their dues and done the all-nighters, and it's just kind of rite of passage sort of stuff.
Yeah.
And then the up and comers are like, well, that really wasn't very healthy or good. Where do you fall on that? Because I think there's probably something to be said for going through the gauntlet and earning those stripes. But I could see the other side too. Like, do I want Dr. Zombie operating on me?
Yeah. Well, I tell you, like the thing is, when you're doing that, you're in your 20s, right? And I don't know. I think most people go into surgical specialties, at least where you're doing that. Like I've always been kind of a night out. Like I can.
You could
when I was that age, I could perform 36 hours a week, the same as I could. And maybe if they tested me, maybe I'm off a little, but I never felt like, and usually the next day after you've been up, like admitting people through the ER, you're not necessarily operating, you're seeing people in the clinic doing administrative tasks and things. So I'm more of a kind of a gauntlet guy. Like, I mean, I enjoyed it, honestly. To me, it's just a rite of passage and you power through it, right? It's like any challenge, right? It's
you
like
rise
a
to the
test or whatever.
occasion.
You power through the difficulty and you emerge on the other side a stronger person. And I think there's something to be said for that in any industry or any job, honestly. Like I think, like I'm not about just beating people down for no good reason. That's not the point.
Yeah.
But the point is, particularly something like surgery, I think you need to be able to work under pressure. You need to be able to make quick decisions, literally life and death decisions. I don't know. I think you just need to be molded under pressure. I mean, that's my opinion. And I'm sure if I was in a debate with somebody, they could probably talk me out of that to some degree. I don't hold that super strongly, but I do see, like, I think if you're going to take the easier path without the gauntlet, then you should spend more time instead of a 5-year residency. Maybe it should be a 7-year residency, right? So you just need the same experience, and you could equate that to any job or industry. Like, I mean, I don't know. I think it's kind of like if you're an investment banker, right? They like get their butts kicked for the first few years of their career and they work a lot, but they learn a lot too, right? And then my friends who are in the banking industry always talk, back when we were going through this, they're like, well, I work more than you do. And I'm like, no, I work more than you do, right? It was kind of like, so
right.
That's the reason I mentioned that, because I have friends who went down that path and they were always complaining about how hard they had to work and pull all-nighters and weekend long, presentations and data dives and all that stuff. So anyway, that's
funny. It reminds me of Colonel Jessup with the Code Red.
Yeah.
You want me on that wall. You need me on that wall.
Yeah, exactly. Yeah. Kind of same deal in the military, I guess. If they're training, look at Navy SEAL training. they don't work for 4 hours and then go for tea and crumpets, right? They are up for 36 hours in cold water. And, I'm not a Navy SEAL, I don't know, but just from the movies and
Yeah.
documentaries, those guys are put through hell. But that means then when they're out there in the real world,
They're badasses. They're pretty tough.
badasses. Yeah, exactly.
Exactly. So tell me this. Have you seen patients where, you were just like flabbergasted, like they roll in and their shoulder is just shattered beyond repair? Have you seen stuff where it's just like there's nothing you could do? And I would imagine there's always something you could do, right? But
Yeah.
have you ever just looked at a patient and after an examination just been like, what the did you do to
Yeah.
yourself?
Yeah, I mean, certainly we all see plenty of that. And particularly when you're like where I trained, which was Emory University, we spent a lot of time at Grady Memorial Hospital, which is a big city trauma center, right? So a lot of crazy gun violence and just blunt trauma, falling off roofs. I mean, getting run over by an airplane. I saw a patient that got literally run over by a large jetliner. His leg got run over,
Whoa.
on the job injury. And that was not a pretty sight. So yeah, occasionally there are.
Left a mark.
Yeah, I am big time. Yeah, it was pretty
Wow.
like I always remember that because I think that's the craziest thing I've ever seen. But
Wow.
so in a case like that, there's something you can do, but maybe the outcome's not ever going to be as good as you hope. But then a lot of things, we see a lot of just bad fractures and injuries. And again, it's kind of a matter of how much you can do for them. You can always make them better. But even the worst fracture, there's solutions and things like that we can kind of get the person out of hopefully most of their pain and get pretty good function. I mean, if it's a shoulder injury, maybe they're not going to be pitching for the Yankees anytime soon. But if they can carry out their activities, daily living, and some recreational sports and things, patients are pretty happy. But it's like anything else. It's a continuum of severity, I guess, when you're dealing with trauma and injuries. So
It's got to be remarkably gratifying, to do what you do and take someone who comes in broken and then getting them back to a place where, post surgery, 3-6 months, a year later, you see them, maybe back to their normal selves or close to it, and knowing that, you had everything to do with that.
Yeah, it is. It's pretty cool. And like I said earlier, I'm a problem solver. Things that are inefficiencies and they're kind of like my pet peeve. I like, good design. I'm kind of a perfectionist and precision person.
Right.
And not everything turns out exactly the way we want, but generally, if you're able to take someone that's got a pretty tough problem and make them a lot better, it's satisfying career still. Unfortunately, there are a lot of economic pressures on physicians and, the way healthcare is bought and sold in the US, which is something that's I turned my attention to maybe, 10 years ago on a part-time basis and more recently on kind of a pretty full-time basis, actually, which is why we cross paths at Health Rosetta. So it's the way, I think we have great healthcare in the US is what I feel. And I think everybody feels that. I mean, there's a reason, like if you're a wealthy person in the Middle East and an oil tycoon, that you get on an airplane and fly to the US for your heart surgery or your other procedures, right? And you're not going to other places because the care here is great. The problem is the way healthcare is, bought and sold in our country, I think, where it's just gotten very convoluted. And I know that's a passion of yours, one path in your career from where you started. And we've been able to make some progress in that regard too. So
unpack that for me, because Doctor, you're a man of many talents. And in my experience, and I hope this isn't going to offend you, it doesn't really apply to you, but most of the doctors that I pass with don't really have the greatest business acumen. They're not really astute when it comes to business because they have no training there. It's something that they really focus on. They're focused on caring for their patients, which is awesome. But in your case, you were able to bridge that gap. So talk to us a little bit about your endeavors outside of the OR.
Yeah, sure. So I think that's true. And I think most physicians, as we discussed, they kind of run this gauntlet. They're generally pretty smart people, but most of us are so busy running our practice or on the patient care side that we don't pay a lot of attention to the business side of it. And as you said, we really don't have formal training in that. So we're kind of like that part, there's money coming in. I'm staying above. Could I fine tune things and make a little more money here or there, or do this or that? Yeah, but just most of us are too busy to pay attention to it, which sounds foolish. And it is kind of foolish, but that's just how a lot of us are.
Right.
And I was that way for a long time, right? The bottom line is I got to the point, and I think a lot of physicians have gotten to this point where we're kind of reaching, or we reached maybe a breaking point. If you're a patient who's interacted with the healthcare system and you've got the crazy high bill from going to a hospital, ER, or anything like that, then you get these bills in the mail and statements and like, hey, you owe, you don't owe this, but here's the bill. It was this crazy number and your insurance paid this. And you may or may not be responsible for this. And nobody really knows how to interpret that. The patients don't, the physicians don't. I mean, nobody knows what they're looking at there. And so it's kind of a really cumbersome system. And so for patients, it's broken. Most commonly, at least the employer's paying the bill. And they've reached kind of unsustainable rates where I think I read recently the average kind of benefit package, healthcare benefit package for a family of four is about $26,000 per family for the employer. And I think the employee is responsible for about $6,700 of that. So that's a lot of money. And that part of it's not sustainable. What most people I think don't realize is on the physician side, our costs are going up just like any other business. But our reimbursement, most of our reimbursement is tied to Medicare reimbursement. And Medicare has basically stayed the same or cut us over the last 20 years. And even since 2020, we're facing another 2.8% pay cut from Medicare next year, which would equate to a little over 10% since 2020. And I would just say the overhead of our practice is up about 23%. So that's about a 33% delta there. So we pay our staff more, we pay more in rent, we pay more for supplies. And unfortunately, at some point, those two curves cross, right? Where you can't stay in business. And at any rate, so most physicians, keep beating their heads against the wall saying, well, I need to do more. I need to work harder. I need to see more patients. I need to just keep doing what I'm doing and hope for the best. And fight with insurance companies, fight with the government, hire lobbyists to do it, all this stuff.
Because that's fun.
Yeah, exactly. Yeah. Well, the point is we've been doing that forever. The AMA does it. It hasn't worked the entire time I've been in medicine. And it's not going to change, right?
It's just not efficient, right?
It's not efficient. Well, that's the crazy thing. If you look at some of these studies, they say like 30-40% of the money spent on healthcare, which is approaching $5 trillion or whatever it might be this year, that 30-40% of it's spent on the transactional side of healthcare, the billing, collections, the administrative burden that we all face. So it's kind of crazy. I mean, the system's wildly inefficient and broken. And just think if we could capture some of that 30-40% and put it back into the system to actually pay for care, that's a big win for everybody and maybe lower costs and things for employers. So I started thinking about this a little bit. I was the frustrated doc I just described, just working harder and harder. And it's funny, if you talk to any doctors, or a group of doctors, all we do is complain about insurance companies and getting paid less. Like, it's just like you go to a cocktail party, you talk with a bunch of doctors, or see them off in a corner. That's what they're talking about, I guarantee you. But here's the funny thing. There are more and more people and employers that either want or need to pay directly for their health care. So I call this kind of the direct pay ecosystem. So where I started or I learned about this was really from local small business owners. So I happened to practice medicine in my hometown. I grew up here in Naples, Florida. And a lot of my high school friends, quite honestly, they are just hardworking small business owners. They're contractors, they're realtors, they're attorneys, they're chiropractors, they own plumbing companies or drywall companies. And these folks work really hard. They make really good money. Here's the thing, they're business people. So when they look at an insurance policy for them and their family, I'm talking about, and they're looking at paying $30 or $40 or $50,000 a year in premiums and deductibles before the insurance company pays anything, they're kind of like, yeah, why would I spend that much money? I'd rather buy a new truck for my business or take my family on vacation or expand my business, whatever. Like, so a lot of people, when I talk about this, they say, well, that might exist in Florida, but it doesn't exist in Tennessee or any place else. And that's a fallacy. It does. It exists in every community. We all know plumbers. We all know contractors. We all know restaurant owners. At any rate, these people are calling my office, asking to get in to see me or get their kids in to see me because they hurt their knee playing soccer or something. And despite having a self-pay policy written out on a piece of paper somewhere in my office, like every practice has, quite honestly, it's stuffed in a drawer somewhere on a computer desktop file somewhere. And when someone calls, when you call most doctors' offices, particularly specialty practices, and say, what's it cost to see the doctor? I just want to pay. I'm out of network. I don't have insurance. I'm underinsured. I have a high deductible.
You get crickets.
Yeah, you get nothing. Yeah, so my office was actually telling my friends, no, I would not see them because they don't have insurance.
Oh, hell no. Really?
Yeah, so it's crazy. And I felt pretty bad about it. The first time it happened, I was like, yeah, I get it. They struggle with this. And I didn't pay much mind to it. But then it happened so many times. And generally it was my wife texting me, and I would have never known this, quite honestly, if these weren't my friends trying to get the business, because they would text me or my wife and just say, hey, why won't Mike see my kid? I'm willing to give him cash. And my wife would be like, well, he will. What do you mean? And they'd say, oh, the staff turned me away. So I would have this conversation frequently, and I'd talk to my staff and I'd say, remember we have the self-pay policy,
Right.
and it's Blue Cross rates or whatever we're going to charge. Right. And they'd say, okay, doc, yeah, thanks a lot. We forgot about that.
No,
Like,
let me interrupt you
yeah,
there for a second,
sure.
because the second time you mentioned that. So we have this self-pay policy.
Yeah.
Is it required? Is it some type of a requirement that you have, or is it just something that you sketched out and said, if someone comes in their cash pay, here's what we're going to do?
Yeah, well, it's traditionally, healthcare is, it's priced kind of crazy, right? There's a charge master price that's way up here.
Yeah.
It's called $1,000 for a office visit and an X-ray. And then Medicare might pay, $150 for that. And then Blue Cross might be here, United might be there. Like it's all over the board.
It's even worse than that, though. It goes by CPT code, and I've looked at hospital charge masters, and they could have 100 different rates for the same exact CPT code. It's
exactly
insane. Yeah.
Yeah. So that's kind of that insanity because healthcare is retrospectively priced, right? You go see the doctor. We might spend 5 or 50 minutes with you. We might do an X-ray. We might do a lab. We might do this. We might do that. Each of those, as you said, has a CPT code. And so that all goes into the system, and then that all gets added up, and this charge master price up here spits out, but Blue Cross might pay here or whoever, right? And so when it comes to cash payers, if someone calls and said, what's it cost to see the doctor, because of the retrospective pricing, the staff actually doesn't know the answer to that question, right? The way that we traditionally dealt with direct pay or self-pay is we had pricing for each of these CPT codes. I always say, I finally realized I was asking my staff to do the impossible, which is predict the future, right? Nobody can do that. So they were having to predict what I would do. And then once they predicted it, they would have to look at the sheet and figure out what the price is. And then they have to calculate maybe a cash pay discount that we might have of X% if they pay immediately. And then they had to negotiate that with the patient on the phone. They couldn't usually answer questions about what was included and this, that, and the other thing. And so quite honestly, it was just easier for them to say no. And it wasn't just my practice. I thought it might be, and I studied it locally and then statewide and then nationally with some peer-reviewed studies that showed more than 98% of at least orthopedic practices around the country will turn away a direct payer, just like I was. So
now it sounds like, to me,
it's crazy.
Do you have a lot of time on your hands? I mean, where did you find time to do all this? Because I don't think this happened overnight.
No, it didn't. Well, it happened with a lot of pain, right? I kind of ran the gauntlet, to use a reference from earlier, where I got so, a couple of times we turned away cash, and it happened over a couple of years, honestly. And I'm just like, oh, this again, why can't we get this right? And then when I started just thinking about it a lot, and some of that was the outside pressure, right? Where I'm like, so I'm complaining about what insurers pay me, but then at the same time, I'm turning away cash. I just set out to figure it out. Not to mention, I was very embarrassed because I think my friends, they didn't say this, but I kind of got this attitude like, oh, you're an important doctor now. You're too good for your high school buddies and this, that, and the other thing. We're not, whatever, right? They didn't say that, but that was a feeling I got. And so
right.
That, as much as anything, motivated me to figure it out. And then, I realized that, hey, if we want to prospectively price healthcare, meaning just give someone a price, we need a product to sell, right? And that product's the healthcare bundle. In fact, most of what we do, not just in orthopedics, but almost any other office-based care, and quite frankly, most hospital-based care that's elective, pre-planned, can be bundled. Now you have a product. And if you have a product, you can use data to price it effectively. And you can price it at a level that patients feel is reasonable, or an employer if they're paying for it, and the doctor feels reasonable. And you can cut out all the bureaucracy in the middle, and hopefully you're saving, let's call it 20%. Now I can offer a lower price, time value of money. I'm getting paid day of service, right? Because the people are on our platform, Health Me, which we haven't really talked about, but we will. Platform I created to help practices and do this and help patients access care. If I can just see the patient and the patient shows up, I can just take care of them. I don't have to worry about a bunch of data entry. I have to make an EMR record, of course, but I don't have to, code for dollars like people say and click all these boxes and spend 50% of my time on the administrative side of things. I can be more efficient. I can see more patients. I can take good care of them. They pay a fee that they're happy with. I receive a fee I'm happy with. And all the middlemen are kind of cut out. Like, that's the perfect world to me, right? If 100% of my practice could be direct pay, local people who are uninsured and underinsured, sharing ministries, but also now the self-funded employer world where you live. To me, that's kind of the holy grail, I guess. Eliminate all the inefficiencies and everyone's happy. Employers pay
Yeah,
less,
well, it
patients pay
sounds like
less. I
sounds
get
like
paid more.
it's
It's all great.
practical and efficient. Like what is there to argue with? Frankly, it's got to be liberating for you as a physician to operate in that environment versus, the traditional healthcare system that has you jumping through all these hoops and, like as you say, just kind of billing for the sake of billing.
Yeah,
Yeah,
exactly.
right. It's great. I think Dr. Marty McCary mentioned in his talk that there's no reason for someone to show up at 2 o'clock in the morning in your room to draw blood. Like this is nonsense.
Yeah, exactly.
But
Well,
it happens every day.
that. I think that's some of the challenge. Like you said, it's kind of a no-brainer. It works for everybody. Why? What pushback would there be to this kind of thing? And interestingly, there's really not any like pushback when I talk to my colleagues, the physicians, when I talk to self-funded employers and others who are paying directly for their employees' care. Like everybody kind of thinks it's great, but to get a medical practice, it's just hard. They all doubt it. Is it legal, Mike? Is it legal? Can we collect cash? Like,
Right.
and now I can say, which is kind of fun. I'd say not only is it legal, the federal government requires you to give anybody a good faith estimate of what you charge, even in-network insured patients. And by the way, if you don't do it, it's a $10,000 up to a $10,000 penalty, same as a HIPAA violation. And they're like, really? I didn't even know that existed. But so not only is it legal, you have to some degree be able to offer these pricing, but it's just hard to get people to change, right? It's just like the 2 a.m. blood draw. Like there's absolutely no reason for that. It wakes the patient up. They get a crappy night's sleep. Nobody wants to be drawing blood at 2 a.m. if you're an employee, but it's just the tradition, right? And, so one of the challenges we have in getting physicians to kind of adopt a new way to do business is just kind of breaking the tradition. And, fortunately, in the time I've been in this space, there's a lot of great people. Marty McCary, who you mentioned being one, who's pointing out the kind of craziness. The movement's growing. Let's just be smart about the way we do business and kind of open up a new revenue stream. And
Yeah.
it's pretty simple. Like you got a product, let's sell it to willing buyers. And we built the technology to make that really easy for them, right?
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. So in your practice, do you own your own facility? Do you rent a facility if you're going to do a knee replacement or a shoulder replacement? And for our audience, is there a difference? Is there a difference between having, a procedure like that done in a freestanding surgical clinic like Surgery Center for Oklahoma, you mentioned Dr. Keith Smith, versus, the big giant hospital that has all the advertising, one better than the other, virtually the same? What's your take on that?
Well, I think the quality of care you get is the same or maybe even better at an outpatient facility, but, people could debate that, but often it's the same doctor. Like if let's say you hurt your knee playing tennis and you tore your meniscus and you came to me and I said, yeah, we'll get you set up. Let's order an MRI, right? If I order the MRI, if you say, hey, I need to live near the hospital, can I do the MRI over there? It's convenient for me. And I was like, yeah, sure, whatever. I just write the prescription and send you there. Traditionally, I would before I was aware of a lot of this stuff. And you go to the hospital, that MRI might cost your insurer $4,000, right? Where you could go to an outpatient imaging center and pay directly for it for $400 or $500, so about a tenth of the cost. And then if you talk about surgeries and procedures, kind of the next level, you come back, you have your MRI, it looks like you need a minor surgery. If I do that at the surgery center, it might be $4,000 all in or $5,000. If I do that at a hospital, it might be $30,000 or $40,000. And so, real world example that happened to me, my son recently graduated from college. When he was a senior in college, he broke his wrist playing some sports. And at any rate, of course, he went through the university healthcare system where he goes to school, which is fine. It's emergency, right? It's not a life-threatening emergency. Went to the ER and they got him stabilized, referred him. I found a great doctor in the system. Amazing doc, took great care of him. I mean, no qualms at all about the care. But the outpatient wrist fracture surgery, the total episode care, if you wrap everything up, was probably close to $50,000, right? Facility fee alone was tens and tens of thousands of dollars. And on our Health Me platform, we have, about 2,300 orthopedic surgeons now nationally, and that same exact surgery at their surgery centers, they owe between $8,000 and $9,000 for everything: surgeon,
Wow.
anesthesia, implant, post-op, 90 days of uncomplicated post-operative care. So there's a big delta there. And I think when you start talking about the self-insured employer space, where, and this is more, a lot more about this than I do, but I'm still learning. But if you look at a couple stats and, call me out if these aren't accurate, but, my understanding is if you look at the roughly 165 million Americans with employer-sponsored healthcare, about 100 million of them, about 2/3, work for a self-insured employer. Those employers are paying the first 75,000 is one number I heard from a stop-loss carrier. Another told me 100,000, but somewhere between, say 30 and $300,000 of the employees care before their stop-loss policy kicks in and the insurer starts paying.
Right.
And so if I'm an employer and I had that episode of care with the wrist fracture, I could have written a check for 50 something thousand dollars or $8,000 or $9,000. How do I connect my patient, the better value proposition there, where it might be the same doctor? Like I said, if I was doing your knee scope and you said, hey, can we do it at the hospital? I'd be like, yeah, whatever. I'm over there on Mondays doing total joints. I'll throw your knee scope on,
Right.
30 or 40 grand.
Yeah.
Versus I say, hey, why don't we do it at the surgery center? And most doctors, like, we don't have skin in the game there, right? So it's kind of like, we don't care so much. We want to go where it's convenient, and, we're pretty accommodating to patients. But I think,
well, as long as you're being paid the same,
yeah, we're getting paid the same yearly. Yeah. It's kind of like, but the employers are the ones on the hook there, or if you're a self-pay patient.
Yeah. And so what Mike is referring to, for our audience that might not be familiar. So if you're in a traditional health insurance plan, you're in a fully insured plan, you're not, one of the 165 million that are self-funded, then your insurance carrier essentially is managing your plan for you. And, your employer is not, quote unquote, on the hook for a deductible, a stop loss premium. Most self-insured employers are going to have stop loss. And that's just a fancy term for a deductible to meet for each belly button on the policy. And that could range. It could range from, the low thousands of dollars into the hundreds of thousands of dollars, into no safety net at all if you're a mega company and you're just going to assume the risk on your own. But essentially what that means is, as an employer, so there are two aspects of this. One thing that you touched on, Mike, is the care is going to be managed prospectively in a self-funded plan. So you're going to have an opportunity to essentially shop for the services before the procedure is done. And in my mind's eye, that makes infinitely more sense than going to a directory and finding a provider that you're choosing because they have a great profile pic, or they're very close to your home and that sort of thing. And that mechanism really is the way that most people find their care in this country. And that ultimately, to your point, is costing the plan tens of thousands of dollars, to be conservative. It's costing you as an employee tens of thousands of dollars over the course of time, certainly, because you're not managing the care, your health care, prospectively. So you're essentially, doing this in the rearview mirror. I mean, just think about it, folks. You don't pull into, your service station, throw your keys at the guy behind the counter and say, I don't know, it sounds funny. Whatever it is, here's a magic card that I have. I'm going to put it down. Whatever you want to charge, just charge the card, and I'll pick it up, tomorrow.
Yep.
That's what we do in healthcare every day. And so it just makes so much sense. And if you are on your A game as an employer, and you are self-funded, and you are aligned with the right advisor team that is kind of quarterbacking your healthcare for you, then you have the ability to manage the supply chain of healthcare. And in terms of what it means to your business and your plan, I interviewed CEO of Raven Alaska, former CEO, Rob McKinney, brilliant guy, pilot, terrific guy. We saved their plan $1.3 million on a $2.8 million spend in year one. We saved them an additional $1 million the following year. And so I asked Rob, I said, and they're a regional airline, small aircraft. They're kind of the life's blood for folks in Alaska because it's a bunch of islands to get from point A to point B. You need to get there somehow. And they provide an incredible, valuable service. So I said, how many airline tickets would you have to sell?
Yeah, exactly.
He said, I didn't do the math, but a lot of airline tickets. So sorry to, kind of go off on a tangent there, but I just want folks to understand what you're
Yeah.
talking about. It's meaningful because now if you have the ability to get an MRI for $400 instead of 4,000, maybe that's the difference between you paying more for your coverage or maybe even getting a decrease or staying flat. As an employer, same, but multiply that by the number of belly buttons on your plan.
Yep.
And so it's a huge deal. And the excess and the waste and the bloat is contributing to this $5 trillion expense that we have on the horizon here.
Yeah, it's pretty crazy. And, every other business, like you said, I like the restaurant analogy. Like, it's like going to a restaurant and you sit down and you don't have a menu. They bring you a bunch of stuff. You kind of know what you might want, but you get served all this stuff. No one knows what it costs. You could ask the waiter, the hostess, the chef, the owner of the restaurant. No one could give you a price. You eat your meal, you go home, and then 30 or 60 days later, you get a bill for $50,000. Like,
Right.
and you're like, why? And it's like, well, because you had the hamburger and the fries, and those are $10,000, right? And so it just doesn't make sense.
Doesn't make sense.
Yeah, and I think one of the struggles, I think, in you understand this because you're in the business of helping these employers save money. It seems to me one of the things I've learned is the challenge that I think folks in the industry have had in getting employers to be able to save money is access to transparently priced bundled healthcare, right? So if you want to shop for something, again, if you want to know your cost in advance, whether you're a patient just who wants to pay out of pocket because they have a high deductible or they don't have insurance, or you're an employer who effectively is paying the first, call it $50,000 of every employee's healthcare. How do you know these costs, right? And I think traditionally there just aren't enough, physicians that have bundled and priced their services. So what I realized as I started doing this is in my practice, just we bundled and priced things, and we did it to solve the problem, right? And we didn't think it would grow business, and then we started seeing how much business it brought in, because someone who's a restaurant owner, right? They come and see us. They tell all their friends, hey, these guys take cash and they have reasonable price and they provide good care. And so just on that, what I'd call like kind of the retail side, where people are just paying, that value proposition and bringing those patients into the medical practice we work with has allowed us to grow a network of about, like I said, 2,300 surgeons now that offer everything, not just surgery bundles, but office visits, injections, physical therapy, imaging, and then surgery as needed. That's all kind of on a software platform where traditionally the practices would use that platform to work with these patients. But we started getting some demand from your ecosystem, the self-funded employer ecosystem, where they said, gosh, we found this practice in Chattanooga, Tennessee, for example, and they have all this great pricing and everything's bundled and it's amazing. Can you connect us with somebody in Atlanta or Dallas or LA or whatever? And so we were making these one-off connections, and we kind of learned that ecosystem, for say a nurse navigation company who's working with a TPA, an employer and broker advisor, how do they find these value-based care, right? And they were one-offing this, generally picking up the phone and calling somebody to practice and kind of doing these single case agreements, and it's super inefficient. So we said, well, gosh, we can take all our providers and just aggregate them into a searchable network, allow in-platform communications, upload, download records and documents, and then adjudicate the payments, to the TPAs, via EDI and whatnot. So we kind of put together a pretty cool tool that allows people now to prospectively price, access, and refer their patients, if you're an employer, into kind of the value-based care system. So that's been cool. Like I said,
It's almost like Amazon for surgeries.
Yeah, kind of. It's kind of funny because I like to say we started out, I kind of started as thinking, hey, we're going to build a searchable Amazon-like platform. Interestingly, a lot of physicians early on were kind of like, I don't know if I want my prices up next to my competitors and whatnot. So they said, can you put it on our website? So that's kind of what we started doing. We became like a Shopify for healthcare. Shopify helps small business owners digitally retail their products.
Yeah.
We help medical practices do it. And that value proposition was able to grow the size of the network to the point where now employers are interested, where we could go back and put them back in an Amazon for the employers. So it's kind of cool. It's definitely kind of come full circle. And it's really exciting, honestly, because I think whether you're like just a local business owner who's self-paying, or whether you're a big employer who's self-insured, at the end of the day, we all want to know our healthcare costs. We don't want surprise bills. The government doesn't want us to have surprise bills. They're passing legislation to kind of support these movements. I mean, it's super fun to go to a meeting like the Health Rosetta or FMMA or those things where you connect with a lot of like-minded folks, kind of the way you and I connected there. But
it's sounding to me like it's not necessarily employee/member facing. It's more either TPA facing or nurse navigators facing, or maybe if you're an enterprise organization, you have a key member of your benefits team that would use the system, and then guide members. How does the interface actually work?
So where we started, like I said, was on this kind of what I'd call a retail direct payer, which is the local small business owners, my high school friends I alluded to. You know what? People are smart. People know how to buy online. And we're on track to do about 50,000 episodes of transparently priced bundled healthcare to mostly retail payers, these small business owners. Guess what? They call the practice, they want to get in. Instead of being turned away, the practice sends them a link, pops up on their cell phone. They Apple Pay, Google Pay, finance it on Affirm, whatever, just like buying something on Amazon. They get in and see the doctor. There's no surprise bills. Doctor gets paid, day of service. Everybody's happy. So the point I'm trying to make is, this is our core businesses on this retail side, and we've built really cool, consumer-friendly kind of digital tools to make shopping for healthcare or buying healthcare the same as buying anything else, right? And we'll do that 50,000 times this year, roughly. So very cool. Patients can do it. They get it. They know how to use a cell phone. They know how to fill out a shopping cart and transact. Now, when you talk to employers about this, and this was kind of my holy grail, I'd say, is just like, hey, if you're an employer, we can create a network for you in the markets you're in. And by the way, even though we started in musculoskeletal care, we're building out a women's health network, a general surgery network, partnering with imaging and gastroenterology. And at some point we'll have every specialty covered. You can basically put guardrails on it. Nobody wants their employees buying surgeries if they don't know that's what they need, but that doesn't happen in the wild with the retail payers either.
Yeah.
Even though people are concerned about that, but you put guardrails. You let them buy an office visit. If they get the office visit, that opens up access to MRIs. And as an employer, you can run all the providers through your quality metrics. And you can do this as a nurse navigation company too, and that's what they're doing. But you can take all the providers, apply whatever quality metrics you want to them. You can do pricing metrics and set filters there. And then you can create kind of a custom curate, a transparently priced network of specialty providers that I think you could turn employees loose and let them at least access the office visits. I mean, in fact, I know you can do it. And
the low ticket items.
Yeah, exactly. And then if the care needs to be escalated, now the navigators and maybe the value-based care team for the employer gets involved and helps direct them to the proper, kind of higher cost solutions that need to be done. But 90% of what you do probably could be covered by the patient. Or, I look at orthopedic surgery. If you look at all the patients that walk into my office, about 8% of them end up getting surgery. The other 92%, we get better with whatever, an injection, physical therapy, time, Motrin, whatever. Yeah, and if you look at the national average, it's about 15% of people need surgery. 85% are cured non-surgically. So, gosh, wouldn't it be great if you could just have the patient log into their portal on, their employer, if it's Walmart or whatever. It's just like, hey, my employee portal, I can manage various things there. It's like, oh, look, in my market, I think I hurt my ankle. I can go to orthopedic urgent care and it's $200. Boom, put on your HSA card or just select it. The practice then deals with Health Me patients all the time. So they reach back out, make the appointment. They run a redemption code that you get as the patient. And if it's a self-funded employer, that just triggers an invoice to the TPA pays. And so, I think I'm pretty confident that could be done. But right now, that's done by navigators and others, which they do a great job at it. I think it'd be nice if we could take a little work off their plate, let them focus on the higher ticket items, I think. But when we talk to employers about that and talk to people that are in the industry, I would just tell you that most don't agree with me. They don't think the patients can kind of do it on their own, that they need more guidance. And I get that. That's what I would have thought, 5 years ago or whatever. But we've proven that patients on the retail side can do this tens of thousands of times a year.
I also like the idea of I believe the DPC model is got a lot of merit, and I think if
Agreed.
you look at a DPC model where direct primary care providers, for those not familiar, it's essentially you're replacing your primary care physician in a traditional healthcare setting where they're seeing on average 2 to 3,000 patients, or 2 to 3,000 patients are on their caseload. It's reducing that number to about 500. And the difference is you're kind of in a subscription based model. So, think my doctor meets Netflix, right? So you're going to pay a monthly subscription fee. And then you're going to have access to a physician that's going to know you, care for you. And there are variations of this, right? There are some virtual models. There are some hybrid where it's brick and mortar and virtual. And then there's, just a standard traditional brick and mortar. And, costs range, typically somewhere between 50 and like $150 a month, right? But now, if they're guiding your care and you link up your system, then you're really kind of getting the best of both worlds, in my opinion. And I think you have the makings of a very effective healthcare plan. Obviously, we need to layer some other stuff in, but foundationally, that's pretty good.
Yeah, I totally agree. And I think that's, it's interesting because when I have a lot of direct primary care colleagues in my market, and they refer a lot of stuff to my practice because they know I have transparently priced bundled care and will treat their clients. Because most DPC practices nationally, they deal with a lot of what I'd call the retail payers, right?
Yeah.
And they're starting to move into the self-funded market, and some are doing that at scale, but most of the ones in my area, in a lot of areas, they're still, majority kind of just cash paying local small business owners, same people we serve. And they have the same problem, right? Like they decide, hey, I want to refer to this person needs a colonoscopy, and their patients can't get in to get one. They get the runaround, they get quoted some crazy price. And so I think kind of the perfect healthcare system for me as a patient, I would say, and I firmly believe this, is maybe there's a digital first interaction and you access orthopedic care digitally. There's some companies that do that. Another orthopedic founder, Brett Miller, who has a company called the Herd app, which I love because it engages those patients, it reassures them, or tells them they need to go to the hospital or whatever. But you got some digital first engagement, both for primary care and specialty care. That gets referred back, they go to see the direct primary care doc, might be able to treat them, and a lot of times they can, and they're done. But if they need an escalation to specialty care, instead of struggling to make that referral, now the primary care doc's kind of the navigator, right? And so right now they kind of turn them over to the navigators a lot of times, which is great, but they could also do a little of that themselves. So we've kind of built our navigation platform to be able to work in that regard too. So if I'm a DPC doc, I want to access DSC docs. So this term that's popped up in the last couple of years that I talk about a lot is direct specialty care. So, and as a specialist, you don't have to go all in. I would love to do all direct pay, but I still have to see insured patients and, want to give them access to our services as well. But if the patient gets maybe a little digital first, direct primary care, employers know their costs, it's all set, subscription. Now they need escalation direct specialty care, whether it's cardiology or GI or women's health or orthopedics. Now that employer, whoever's paying the patient, they know exactly what that office is going to cost. They know what an MRI costs if they need it. They know what surgery costs if they need it. They know what physical therapy costs if they need it. So like now you're talking about like kind of the whole soup to nuts, ecosystem is transparently priced, prospectively priced, I guess I should say.
Yeah.
And so that to me is kind of the holy grail. If you can put all these pieces together. So that's one thing we're trying to do at Health Me. We really started, at our core, the medical practice is our client. We help them bundle price and retail their services. Our secondary clients, if they can do that, now they can serve the patients and the employers, right? So that's kind of our secondary client. And now as these ecosystems emerge with the DPC and whatnot, how do I let those people access direct specialty care? We've built this CareDot platform that I talked about that allows people to just say, yeah, I can just make this referral digitally. I don't have to pick up the phone. I don't have to, refer the patient, and then the patient shows up and the person at the desk doesn't know what they're talking about and sends them away. It's all streamlined. It's all digital, the payments, the communications. And so I think, that I think if whether you're a doctor or a patient or a payer, like that's the holy grail, I think, right? I mean, I use that term a lot, I guess, but it really
Yeah.
is, right?
Yeah.
I
Well,
mean,
I mean, just think about it commonsensically. I think a lot of this stuff is overcomplicated, or maybe it's overcomplicated by design. But if you just think about it as a small business owner, and then you could scale it, and you could say you're Steve Squeary, the CEO of American Express, right? It's just you're paying a lot more, right?
yeah, yeah.
But so if you're paying though, doesn't it just make sense to manage healthcare prospectively instead of in the
Yeah,
rearview
totally.
mirror? Because either way, you're going to pay, right?
Yeah.
Let's face it, we're not magicians, we're not wizards, whether you're a doctor or an insurance advisor. If a cancer is going to be diagnosed, the cancer is going to be diagnosed. If a leg is going to be broken, a leg is going to be broken. So now it's a matter of, okay, we need to manage the two things, the quality and the expense of that care. Always put quality first. You want to do your diligence and make sure that the quality is as high as it possibly can be. That's not going to a directory with every physician under the sun and picking one because of their geographic location or because they have a nice smile. The wrong way to
Yeah.
go about it, right? So if you zero in though on quality, and then you have help me at Health Me.
Yeah. Yeah.
Right? Go to Health Me, and they will help you. You at the very least will know what the all-in cost is. That's
Mhm.
huge, and you have a basis for comparison.
Yeah, I think that's kind of a crazy thing because it does obviously, like, to anybody, any rational person, even an irrational person, you tell them that, they're like, yeah, that makes total sense.
Right.
The funny thing when I talk to a lot of physicians and practice CEOs and employers and broker advisors and everybody in the ecosystem. And the funny thing is, I think some people, I think you hit the nail on the head when you said that the way it's done now is just way overcomplicated. And I don't think it's necessarily by design. I think it's the way it evolved. But now that it's there, I think a lot of people like that. I think if you're a
Mm.
commercial insured, you like the complexity of it, right? There is a resistance to change there, but a lot of times I hear it's like, yeah, it sounds like too simple. Like that can't work, can it? And then you say, well, yeah, we did it 50,000 times this year and 25,000 times last year. And then people are kind of
Right.
like, oh, I guess it can. But
Right.
part of the challenge is connecting all the little pieces in the ecosystem. And then I think the coolest thing about this, honestly, is because it sounds like I'm talking about the impossible, right? We can lower costs for employers and patients. We can improve quality because if you're going to charge a certain fee and there's some competition in the market and people can actually shop and look at quality metrics and things, you're going to try and do a better job so you get these patients coming in. And the reason you want these patients coming in if you're a physician is you're going to get paid the same or better than you are from commercial insurance contracts. And those
Without
three
any of
things,
the red tape.
yeah, without any of the red tape, exactly. So you can offer a lower price. You're not spending that 15, 20%. But I think one of the things of coming this from the physician side, I try and let people know in the ecosystem, like, it's not about the price, right? Like, I talked to a lot of people in the self-funded ecosystem. They're like, well, what percentage of Medicare? What is this? What is that? And that depends on the venue of care, right? A Medicare reimbursement to the hospital is more than an HOPD, a hospital outpatient department, which is more than an ASC generally. And so it doesn't really matter. You just want to look at what the price of the bundle, and then you apply quality metrics. And most people I talk to at least talk that they're willing to pay more for quality, for convenience, keeping people local. But then on the same time, I hear people like quibbling about, well, this bundle locally is, $1,500 more than I could do it in Texas for. It's like, we'll put the patient on an airplane, put them up in a hotel for 2 nights, travel them to Texas. They don't want to do that. They want to stay
Right.
local. They want to see the doctor they know. And there's market differences, right? Healthcare, even Medicare, pays different fees in LA than they do in, Phoenix, than they do in Naples, Florida, than they do in Hayhira, Georgia, right? Like, it's
Yeah.
like I think people have to understand that there is variation in price, that for the physicians to do something different, they need to be paid at a level that keeps them in business. Because if they go out of business, then all this is going back to the hospital. So I'm kind of a physician's advocate in this, but I give physicians sound advice, right? Like if they're telling me they want, and more often than not, quite honestly, it's anesthesia, the surgery centers that are asking for some crazy price for their bundle. And it's just like, look, that's just not market based. I get that's
Right.
your charge member or your charge master price, but here's what will work that'll get you business. And guess what? It pays you pretty damn good.
Mhm.
And same to the doctor, same to anesthesia. And we're getting better and better at it. As the market grows, I think people have started to seek out this business rather than just say, hey, I wanted this as novelty. Let me do it a little bit and see what happens. So
Yeah.
anyway, I do like to make that point. I think it can be a win-win-win, but I think we also have to be cognizant that the doctors want to be paid reasonably. They can't keep taking cuts, but the employers can pay a lot less because we're getting rid of the administrative burden. And the patients want access to high quality local care. They want to see the doc that their brother saw or their sister or their friend. They want to see Dr. Jones in, Chattanooga because he's the best knee guy in Chattanooga. They don't want to get in an airplane and fly down to see me, even though I'm a
Right.
damn good knee guy too, but they don't know who I am. They don't want to fly across the country. So anyway.
Unless Dr. Jones at Chattanooga is Dr. Rusty Nail. He
Yeah.
may be
Yeah.
Chattanooga, but you might want to
Yeah. So,
aim a little higher than that. And nothing against Chattanooga. So yeah, this is all really interesting and unbelievably commonsensical. At the end of the day, it really is about two things. It's about price and it is about quality. And I get what you're saying. Like I don't think the answer is to squeeze the blood out of a physician, holding him to some ridiculous, Medicare standard, right? I also think that the economies of scale, when we are bundling everything together, just make it such that it becomes like if we broke this apart and we calculated, on a HIC for 1,500, a hospital bill, what all of these different services would be. Yeah, you might be able to zero in on any one of them and say, oh, that's 1,500% of Medicare. That's ridiculous.
yeah.
But put it all together in a bundle, and now all of a sudden your comparative expense to Medicare is not a huge multiple. The doctor is
Mhm.
being paid appropriately, the anesthesiologist, the surgical team, the
Mhm.
facility, but the plan is saving money. The patient
Yep.
has a better experience, hopefully a better outcome. You're keeping the money flowing in the community, right? And so I
Yeah.
just,
Yeah.
got done interviewing Michael Fine, Dr. Michael Fine, who wrote on medicine colonialism. And he's, makes an excellent, kind of expose point of saying our local communities with a lot of what's going on in healthcare today. And what
Yeah.
you're doing is the exact opposite of that. You're basically encouraging free market competition within your geography. And the hope is that you can direct patients to high quality providers in your market. And to your point, everybody wins. It doesn't have to be a losing proposition for any of the stakeholders.
Yeah, exactly. And I think that's what's so fun about it for me. It's like, healthcare is super complex, particularly the buying and selling of healthcare. As we've both mentioned, it's way more complex than it needs to be. And it's just really fun to be able to say, look, let's distill this down to the key stakeholders, right? The payer, the patient, the doctor, connect them with good technology, adjudicate payments, make it all easy, take some of that complexity out of it to, to
It's
take it out.
not complicated. As an employer, do you want to run the risk of paying 220 grand for that knee replacement, or would you rather know in advance that your all-in cost is going to be 35 grand? It's
Yeah,
it's
exactly.
it's not much more complicated than that.
It
Um,
really is.
hey, I really appreciate you joining us today and all that you do. How can folks find you and connect with you, and what types of folks are you interested in connecting with?
Yeah, I could talk to anybody about this for days on end. So, any rate, but yeah, if you say what's our focus, any doctors that might be listening to that want to learn how they can, start, enter this direct pay, direct specialty care, or even direct primary care, I can refer them to the right people there too. But anyone that wants to get into the direct care business and really simplify their practice, we can share my email in the show notes and maybe a link to our website, which is Health Me Docs, HEALTHME docs.com. At the same time, I'm guessing a lot of benefits advisors and maybe self-funded employers listen. And if they want to learn how they can get pretty simple turnkey access to transparently priced bundled specialty care, would love to connect with anybody that wants to see our healthcare system evolve into the system that you and I described today. I think there's a real, I think this would have been a pipe dream, 10 years ago. I think now we're on the cusp of this actually really happening and really scaling to a level where we all see benefit, whether we're doctors, patients, or employers, right? So very
100%.
cool.
I mean, the important thing, for folks to know is that it's possible. It's within your grasp to take control and manage the cost of healthcare. Don't believe healthcare's big lie that you have no control over the cost of healthcare, because nothing could be further from the truth. So it's really just a matter of you, first, I think, suspending disbelief and saying, I think we can do this. And then once you kind of jump in the water, you'll probably be asking yourself, what took us so long?
Yeah, exactly. I
What
hear
took
that
us
all the time. I hear that all the time. So yeah, 100% in agreement on all that.
Awesome. Well, hey, Dr. Havig, thank you so much for being a guest on our show. We're appreciative of all that you do, of all that you contribute to your local community, your fellow Americans. And now, I mean, the beauty of what you're doing today is you have the potential to reach and impact many, many, many lives just with this one endeavor and initiative. So I guess those 36-hour shifts, they may have paid off.
Yeah, they did, I guess. Yeah,
Yeah.
definitely.
So
So,
once again,
cool.
thank you for joining. And folks, until next time, peace and love always. This is Ray Cobra signing off. Have a great one.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show. And join us on the next episode.